and she's going to talk today about neonatal palliative, supportive, and end-of-life care.
السلام عليكم ورحمة الله.
So, can you hear Dr. Nevin?
No.
So, Assalamu alaikum. Can you hear me now?
Yes, it's clear.
Okay, thank you. So our presentation today, as Dr. Yasser mentioned, about the neonatal palliative care or the end-of-life care. In this presentation, we will come to some definitions, aspects of neonatal palliative care, then we will audit the palliative care practice and the recommendation. So as a background, the advances in antenatal diagnosis and the neonatal care all increase the need for decision-making about end-of-life care for the neonate. The antenatal diagnosis of abnormalities not compatible with life are being confirmed earlier in the pregnancy, and the plan for palliative care may be needed at any stage, either antenatally or in the perinatal period, for example, because of extreme prematurity or after the diagnosis of a condition with a very poor long-term prognosis. Palliative care planning involves multidisciplinary team planning, and the choices in care may vary until the end of life to allow the transition into and out of active, supportive, and end-of-life care. The decision about the end-of-life care planning should be based on the best possible information about the diagnosis and prognosis of the underlying condition, and the palliative care should only be considered if the baby has a life-limiting condition. The joint decision-making with parents need open communication and clear documentation. The care plan should cover all foreseeable outcomes and should be flexible enough to allow for changes in the condition of the baby, as well as the parents' wishes and views. Here we will come to some definitions in this context, including the neonatal palliative care. It's defined as the planning and provision of supportive care during life and end-of-life care for the baby and his or her family when managing an appropriate life-limiting condition. We will come to the term DNR or do not resuscitate. This is a treatment decision taken prior to event of cardiac or respiratory arrest with the consent of patient, or where that is not possible, proxy consent of next of kin, where care providers will not provide cardiorespiratory resuscitation. This does not preclude or stop to any degree normal care and treatment being given to the patient. Other terminology we will use in this context are withholding, withdrawing, and limited escalation. Withholding refers to refraining from starting cardiopulmonary resuscitative measures or declining of starting life support measures. Withdrawing refers to stopping cardiopulmonary resuscitative measures or life support measures. Limited escalation refers to clinical guidance setting out limits to appropriate treatment choices for patients approaching the end of life in the event they become actually unwell. Another term, unanticipated losses. This is when the family has no opportunity to plan or prepare for the death, like when they experience an early loss, such as miscarriage or fetal demise. If the baby is in NICU and expected to die, the provider here needs to determine the family's wishes for resuscitation of their infant, or if they wish to sign DNR. This we have to mention that many families are unwilling or unable to face decisions that may make them feel they are responsible for ending of their baby's life. Here, maybe the use of A&D term mean allow a natural death is more acceptable than DNR. The anticipated losses, as we know, the advances in genetic and technology enable many families to know well in advance that their baby has a potentially life-limiting condition. So they have the time to make the decision early in the pregnancy, whether they want to come to medical interruption of the pregnancy or medical interventions such as neonatal surgery or preparation for fetal or neonatal death. The aspect of neonatal palliative care include established eligibility for baby for palliative care, family care, communication and documentation, flexible care planning, pre-birth care, transition from active postnatal to supportive care, end-of-life care, as well as post-end-of-life care. First, establish eligibility of baby for palliative care. This can be considered in 5 broad categories, as we know the palliative care criteria. First, antenatal or postnatal diagnosis of a condition that is not compatible with long-term survival, like bilateral renal agencies, anencephaly, chromosomal abnormalities. The second one is antenatal postnatal diagnosis of a condition which carries a high risk of significant morbidity or death, like severe bilateral hydronephrosis and impaired renal function, severe spina bifida. The third one is babies born at the margins of viability where intensive care has been deemed inappropriate, like babies born at 23 weeks with bilateral hemorrhagic parenchymal infarct. The fourth one is postnatal condition with a high like of severe impairment of quality of life, either when receiving life support or that may at some point require life support, like severe hypoxic ischemic encephalopathy. The last one, postnatal conditions which result in the baby experiencing unbearable suffering, like severe necrotizing enterocolitis, where palliative care is the baby's best interest. Palliative care should only be considered when the diagnosis is confirmed antenatally or postnatally by genetic testing, scans, or other investigation, and multidisciplinary team has agreed the diagnosis and prognosis. The prognosis should then be explained and discussed with the family, and some circumstances where palliative care may appropriately coexist with active management, particularly in the face of uncertainty. Another criteria for palliative care and do not resuscitate order. Here we will come to the UAE experience in neonatal care, some information. The outcome of low birth weight babies in Abu Dhabi has been improved over the years, and it is similar now to that in developed countries. The current incidence of the low birth weight at delivery is 8.8% compared to 15% in 1995 across all the Emirates. The neonatal mortality rate is reported as 6.9 per thousand birth with prematurity, preterm birth complication, and lethal chromosomal anomalies accounting for 77% of all deaths. Consanguinity is about 50%. It is estimated that there are at least 213 genetic disorders and congenital abnormalities in UAE population. many of which are likely a result of the practice of consanguineous marriage. However, it did not increase either low birth weight or prematurity and admission to NICU. There are some circumstances that can affect the palliative care management and planning. As we all know, the surrounding inside the NICU for neonate with aggressive care and life-sustaining technology with all sorts of life support systems. Also, sometimes parents are not allowed to come inside for fear of infection. The ratio nurse-baby and doctor-nurse still low sometimes. When extended to home care from NICU, issues for day-to-day procedures, nursing such as tube feeding, oxygen therapy, ventilation protocols remain critical. In addition to ethical issues, education, expertise, planning all can affect. The crucial decision-making as to whether withhold or withdraw life support is difficult to take and need professional support and guidance. Here we are all obliged to provide comfort, warmth, emotional support, feelings, and empathy throughout and even after demise. The key ethical principle is non-maleficence, as the intention to avoid causing harm in a situation where benefits of treatment are not clearly beneficial. For some, emotional weight of withdrawing a treatment is greater than that of withholding a treatment. Actually, in certain situations, withholding would be better than initiation of treatment and then withdrawing it. The ethical framework for doctors for withholding and withdrawing life support should be guided by certain ethical principles. These are first, respect of autonomy, means the doctor or the parents have the right to participate in the medical decision making. Second one is the beneficence. The clinician should act in the best interest of their patient. Non-maleficence means do no harm. The justice requires that all people be treated well and fairly, and health resources to be used equitably. For patients, ethical issues can arise in situations related to medical decision-making, including who makes them, issues of futility, conflict of value between loved ones and or between clinician and patients, and professional values. Decision-making, the principle of autonomy means the parents of the patients have the right to accept or reject recommendation made by clinician, but it doesn't mean that they have the right to demand intervention which are not medically indicated. Determining best interest means determine patients' pre-existing notion of acceptable or stable quality of life and what the patient would have described as sufficient decrease in quality of life to be intolerable. Cost and benefit assessment, the benefits and risk of each planned intervention. The second, the characterizing risk, degree of suffering and pain associated with the intervention, including the ability to lessen the suffering. Then the expected prognosis with and without treatment, including mortality and long-term consequences. We'll come to the planning palliative care with families. The first aspect is the communication. The families will require support at many levels as they will be shocked, frightened, stressed by the knowledge that their baby has life-limiting condition. And when planning palliative care, it is essential, it should be a multidisciplinary discussion, and the discussion should be conducted in a quiet and private settings and the family to have the opportunity for a third party being present to support them. The parents should be given the time to assimilate information and to discuss with wider families or friends if they wish. And the phrase withdrawal of care should be avoided, and palliative or comfort care should be offered. An interpreter should be available if required, and preferable not to be a member of the family. Psychological support. The parents should have the chance to collect and create mementos with baby. They have the opportunity to see a trained counselor and should offer written information about the relevant voluntary organization and support groups. The spiritual support care should reflect personal, cultural, spiritual, and religious wishes. Social support also should be offered. Advanced care plan. Any baby being discharged home or to a hospice for palliative care must have an advanced care plan completed and agreed. This includes resuscitation guidance and contact details of key members of staff, and it must be printed and disseminated to the appropriate people. Flexible parallel care planning. This when some babies who survive longer than expected during supportive and end-of-life care. It's vital that care planning is continuously reviewed in the best interest of the baby. There should be a parallel planning for transition period into and out of active, supportive, and end-of-life care. Pre-birth care. When the diagnosis of life-limiting condition is made antenatally, it may be appropriate for palliative care to begin prior to the planning, to begin prior to the birth of the baby. This should include an approach and limitation to resuscitation at birth and location of ongoing care. Transition from active postnatal to supportive care. In some situations, a rapid assessment by a senior clinician may be needed to confirm a candidate condition for palliative care, and occasionally specific tests may be helpful, e.g. rapid karyotype of pooled blood in the case of anomalies suggesting of life-limiting chromosomal anomalies. Location of care and death. It's depending on the situation and the level of support required to the baby, and it might be in the delivery suite, postnatal ward, neonatal unit, local hospital, home, or children hospice. The clinician should discuss with the parent these issues and take their wishes into account. The mother's health must be considered and planned for as well. Management of end-of-life symptoms. There is limited data for neonate evidence and guidance for the treatment of end-of-life symptoms in opposite to adults guidance. Here we have pharmacological and non-pharmacological means of management for symptoms like pain, dyspnea, agitation, irritability, and secretions. The physical comfort care, measurement like positioning, skin care, mouth care, human contact, including breastfeeding if appropriate, skin-to-skin contact, and true developmental needs should not be forgotten. Symptoms like pain, distress, and agitation can be treated pharmacologically by paracetamol and ibuprofen. If not sufficient, using of morphine. Here we have to mention that there is no limit to the dose of morphine for relief of pain or distress, even in the knowledge that this may cause respiratory depression. The non-painful routes of administration are recommended, and furthermore, it is illegal to give any medication with the intent of hastening death. Midazolam, another medication used in seizures and agitation. There is no evidence was identified on how to provide safe and effective analgesia, particularly in community settings, and the studies should aim to provide evidence-based option to help manage breakthrough pain in the community. Here are some suggested pharmacologic medication tables. We will come now to non-pharmacological management, including decreasing stimulation, massage, skincare, mouth care, elevating the head, repositioning, or dyspnea, fluid restriction, gentle suctioning, all may be beneficial. Swaddling, skin-to-skin contact, and non-nutritive sucking. Skin-to-skin interaction is known to decrease pain, improve labored breathing, and have positive psychosocial effects, as well as promote comfort and bonding for both mother and baby. They are effective in alleviating dyspnea and agitation as hypoxia, hypercapnia that can occur during this time. Also has a natural sedative effect. Respiratory symptom management, including the respiratory distress. As we mentioned before, non-pharmacologic treatment intervention include positioning, and pharmacologic management option include opioids. Morphine is commonly used, and it is effective at 5% of the dose used for pain. Excessive secretion, including fluid restriction, positioning, oral suctioning. Pharmacological management, including atropine, 1% ophthalmic solution may be given sublingually, though most evidence is adult-based at this time. Glycopyrrolate, orally or IV, is given, and it is the preferred pediatric anticholinergic option. We will come here to compassionate extubation. There is no consensus on the best way to discontinue mechanical ventilation in the context of end-of-life care. Experts recommend initiation opioids with or without benzodiazepine, and then slow wean of ventilator settings. Parents should be involved with non-pharmacologic comfort if able to. Anticipation and prevention of pain, agitation, dyspnea symptoms is paramount to decrease familial and neonatal discomfort. Should explain to the parents what is going to happen and when it will happen and which member of staff will be present. Withdrawal of less invasive forms of respiratory support, such as nasal CPAP or nasal cannula oxygen, may be appropriate if a baby is dying, and continued provision of respiratory support only serves to delay death. Regarding nutrition, feeding, and GI symptoms, the goal of feeding is to provide comfort and reduce the stress from hunger. The route of feeding should be what is the most suitable for baby. In those infants in whom the duration between withdrawal of life-sustaining care and death is expected to be short, it is reasonable to cease all feeds if it felt feeding could cause distress. Considering stopping nutrition or hydration is appropriate only if to do so will not result in hunger or distress to the infant. Gastrostomy, nasogastric, and feeding will all require parent training and professional community support. The benefit of surgery to allow feeding either via intravenous or intra-route must be balanced against the burden of the intervention and the prolongation of death. Symptoms like vomiting, constipation, urinary retention all should be treated. We come here to familial distress and psychosocial care. Providers should be mindful that family members may feel guilt and question their decision. Some families have moral distress in believing that withdrawing technological support is not permissible in their culture or religious customs. Here, framing discuss in a way that a family does not have to decide anything may be helpful. For example, the physician may say something like additional technological support is appropriate and will increase the infant's suffering. I recommend we increase the palliative care service and work intensively now to support comfort for the infant. Supporting women who are lactating is important here. Regarding investigation, monitoring, and treatment, monitoring is not necessary unless may be used if helpful to parents. Investigation should only be performed if the results might lead to treatment that will improve the baby's quality of life or help the diagnosis and management of subsequent pregnancies. Immunization should be given as per immunization program unless contraindicated. Resuscitation plans. Limitation to resuscitation should be discussed, documented, and regularly reviewed. Comfort and dignity of the baby should be maintained. Changes in appearance of the dying baby. Staff should explain to the parents the physical changes that are likely to occur as their baby dies. Terminal gasping should be explained in order to reassure parents that this is not an indication of suffering. Parents should be made aware that the time until death can vary from minutes, hours, sometimes days, or longer. Post-mortem examination. A post-mortem examination should be offered to all parents of infants that die, even if the cause of death appears obvious. This may identify unsuspected problems. Information gained might also be important when the parents think about another pregnancy. Organ donation. Some parents may wish to donate their infant's organ. It is important to establish if that's possible or not. Donation of heart valve is usually considered for infant whose death is expected within a specific time period, and the infant should be above 37 weeks gestation with weight of 2.5 and above, and the valve must be harvested within 48 hours. Post end-of-life care. Local guidelines and paperwork should be completed. Bereavement support should be provided and continue throughout the baby's death and beyond. Parents should be offered a follow-up appointment so they can have the opportunity to discuss relevant events, any unanswered question about their baby's condition and care, as well as post-mortem findings where applicable. Staff support. Neonatal staff should have access to clinical psychologists and provider of spiritual care. Staff should receive training in the principle of palliative care and communication with parents. Staff should be offered debriefing after death. That is, allow space for team members to develop shared narrative of events, appreciate practice that has gone well, and consider alternative ways that family might be supported. Future family planning and palliative care situation. While some parents may wish to become pregnant again soon after their infant dies, some will need more time before they emotionally and physically ready. Parents should be directed to available resources for support. And now we'll come to auditing the palliative care practice. There should be regular audit for the care pathway implemented to assess the quality of care provided. This area include the palliative clinical skills and training details of staff members should be maintained and reviewed annually. Adherence to palliative guideline practice, details of documentation, parent communication, and support provided to family, regular survey for parents and staff feedback on quality of palliative services provided, and parents and family satisfaction, staff training, and their confidence in providing palliative care. At the end, we have to mention that end-of-life support is not well utilized in Middle Eastern countries, as the concept of DNR is not clearly recognized, and there is a lack of DNR policy in most Arabic and Islamic countries. In addition, is the confusion with religious and legal positions on DNR and poor communication between the healthcare provider and the family. Efforts should be made to improve and optimize end-of-life care by training medical staff and address the urgent need for the development of palliative care. The non-resuscitative and limiting life support should be considered in a neonatal terminal or untreatable disease with a low chance of survival to minimize the suffering of the dying baby. And thank you so much.
Well done, Dr. Nevin. It's really very well prepared. Thank you so much.
Yeah, thank you. Thank you, Dr. Nevin, for this really comprehensive, good presentation of such a complicated, sad topic in the NICU. And I liked her tackling most of the important points that we need to discuss. And it was very updated. I can see from her references, most of them are within the last 3-4 years. And I really enjoyed the presentation. It raised a lot of concerns that we all share, and we all agree that we need to discuss. So the floor now is open for any question.
Dr. Muhammad Said, Dr. Yasser from Neonatal ICU Qasim and Children's Hospital. Thank you, Dr. Nevin, for this presentation. Actually, me and Dr. Ahmed were just discussing because we are listening to you. It is very well prepared, well done. So I think most of us will need, if you can just share this one through email with colleagues, so it will be helpful because you have very updated knowledge about this part. So it will help most of us to be with us, to review it every now and then in case we have discussions with this part. Second, Dr. Yasser, I just need to open the subject with you this part. As you know, Dr. Yasser, your unit is quite busy. Our unit is quite busy. Dr. Amina also quite busy. I don't know, because I have been working in Saudi Arabia before, and they have something called custodial care. They are keeping such baby in that unit, and they are providing the care in that one. So it is not essentially to be in a neonatal ICU. It can be somewhere in the hospital under the care of neonatal team. In view of our situation, we have over-admission, we have a lot of issues to be working, we need to have a care, and at the time for sure, at the time I'm speaking with you now, and we have almost 2 babies who is DNR. We cannot do a lot for them. So any clues, Dr. Yasser, from your previous experience, to keep those babies in special care area or something like this?
So, yes, sir.
Hello?
Yes,
Can
now
you
we can hear you. Yes, we can hear you.
We just are having a problem with the sound. I'm not sure if the others can hear us and clarify the question.
Now we can hear you, Dr. Yasser. Can you hear us?
Yeah. Can you
Yes.
repeat the question, please?
Okay, Dr. Yasser, we were speaking about that we need Dr. Nevin to send us this good presentation because it has a lot of information for us and we need to be disseminated between colleagues in MOH.
Yeah, I agree. This is the start of setting up a new guideline that's dedicated only for NICU, if I got your question right. And as far as my last discussion with Dr. Allam, who is one of the experts in this field in the Middle East area, he said there is no single guideline for DNA policy in the Middle East area. So if we are going to set up this guideline, we will be the first group of NICU who will do this setup. And I think this has been already discussed in the Neonatal Service Committee. And we are in the process now of discussing with multidisciplinary subspecialties to set up a new guideline only for neonatal palliative care and DNR policy. I hope this answered your question, Dr. Any more questions? So Dr. Khalid would like to make a comment from our side.
Hi, good morning, everyone. Khalid here. I'm one of the consultants. Recently joined Umran Hospital, and I started to know a little bit about the EHS. Just can you confirm that you can hear me clearly before I proceed with my comment?
Yes, go ahead. Go ahead, Dr. Khalid. Welcome.
Thank you. So first of all, thanks for Dr. Nevin for this, what I would describe as a very excellent and extensive review of a rather challenging subject, as always. And I believe here we have so many questions that will continue to be unanswered. And I think this is would constitute, as just Dr. Yasser alluded to, that will be a platform to establish a more solid sort of platform for this sort of problems. The areas that concerns me comparing different health system settings. I got the opportunity to practice in the Middle East and also in the UK back. So the main areas I think also we need to kind of start to do some work on is the first I would highlight is the presence of what we describe as a hospice or a terminally ill newborn with a very short life. And I think so many families would like to cherish these moments and try to spend as much time as possible with their the dying, let's say, newborn. And I'm not sure within the EHS Northern Emirates if there is anything facility like that. And if not, is this something should be put on an agenda at a national level to try to cherish this very short life. The other thing is what we sometimes refer to the best interest of the infant. Sometimes we kind of a little bit ignorant, I believe, and arrogant on deciding of we know better what is in the best interest of the infant. And that's proven throughout the decades. That is on so many cases and in so many case reviews that clinicians sometimes they fail families in a way or another by assuming that they know better. And in these cases, here comes my question about presence of ethical committee. And I think that will take a very big burden from the clinicians and from the parents as well, if there is an establishment of an ethical committee to decide on the cases which are not straightforward, not white and black. So I think that's one of the things that should be put on the agenda, ethical committee for difficult palliative cases. And with Dr. Nevin highlighting the issue about the amount of genetic disorders, I'm not quite certain about going before what we call a prevention step rather than therapeutic is where are we with pre-marriage genetic testing and genetic counseling? And maybe it is there, maybe it's very well established, and I'm more than happy to be educated if that's already existing, the pre-marriage genetic testing and counseling. Prevention is definitely better than cure. And a part of this setup is with the palliative care team. And I think if we are talking about an advanced level neonatal units, a palliative care should be part of that. And with regard to the organ donation, I think that is another thing which is very important. I'm not sure as well if there is an organ donation coordinator here, a number that people can contact. So many families are very willing to be involved in this aspect of the end of life. And it needs to be done in a very timely manner and promptly without any sort of obstacles or challenges in the way. So I think this is, I'm not expecting answers. I'm just here throwing some ideas because as I mentioned, this is, I think, just the beginning of a very important area of improvement and area of discussion. There is so many progress in this field, and I think we need to catch up with all of these aspects. Thank you, and thanks, Nevin, once again for your elegant presentation.
Thank you, Dr. Khaled. These were very valuable comments, and for sure we will take all these considerations in our discussion with the Neonatal Service Committee meeting. Any more questions? Okay, I think it's time to conclude. So thank you all, and special thanks for Dr. Nevin for this presentation. Just to let you know that the floor is still open. If you have any suggestion, any ideas to throw into this topic or other topics, just feel free to contact any of us, and we will put all these ideas into our Neonatal Service Committee meetings, and we will discuss whatever concerns you have or any kind of brilliant ideas that we can use in the future, inshallah. Thank you very much all, and have a wonderful day. Assalamu alaikum.
Thank you so much.
Thank you very much.